Good afternoon and welcome. Today's keynote is titled, The Change and Acceleration of Healthcare Delivery Due to COVID-19. To cover this topic, we are thrilled to offer a keynote panel with three dynamic healthcare leaders representing different vantage points of healthcare. So many of you are involved in the care continuum of DME and home care services. In that continuum, we are all impacted by actions and strategies instituted by healthcare providers, payers, and medical device manufacturers. That's why I'm so excited for you to hear from our panelists today, who represent each of these stakeholders. First up is Dr. Carlos Nunez, ResMed's Chief Medical Officer. Dr. Nunez leads a global multidisciplinary team that provides the clinical and scientific expertise necessary to inform the strategy of the business units and functions across ResMed. This includes the safety, quality, and regulatory efforts that touch every phase of the patient experience and product life cycle, as well as driving innovation and public policy. Prior to joining ResMed in 2017, Dr. Nunez was Senior Vice President of Medical Affairs for Becton, Dickinson & Company, and prior to that, Chief Medical Officer at CareFusion. Dr. Nunez received his medical doctor degree from the University of Miami School of Medicine, where he also completed his postgraduate training in anesthesiology, critical care medicine, and clinical research. Before beginning his career in the medtech industry, Dr. Nunez was a practicing anesthesiologist, intensivist, and hospitalist, director of critical care research, informatics, and analytics. Our next panelist is Dr. Kathryn Teng, who is the U.S. Chief Primary Care Officer for Babylon Health. Dr. Teng has 25 years of clinical experience as a practicing internal medicine primary care physician in 4 healthcare systems. In addition to her deep understanding of clinical workflows, Dr. Teng has extensive experience in recruitment, retention, and career development of physicians and advanced practitioners. She was Division Chief of General Internal Medicine at Metro Health from 2015 to 2020. She was also Service Line Medical Director for Adult Primary Care, Behavioral Health, Geriatrics, Dentistry, and Express Care at Metro Health from 2016 to 2021, overseeing budget and operations for over 250 providers. More recently, Dr. Teng led efforts to rapidly convert her team to virtual care due to the COVID-19 pandemic. In addition to her experience in traditional healthcare management, Dr. Teng directed and created a Center for Personalized Healthcare at the Cleveland Clinic, focused on integrating genomic information into the standard practice of medicine. Dr. Teng completed her medical degree and residency at Vanderbilt University School of Medicine and holds a master's in business administration from Case Western Reserve University, Weatherhead School of Management. Our third and final panelist is Dr. Charles Zonfa, Chief Medical Officer of SummaCare, a regional provider-owned health insurance company based in Akron, Ohio. Dr. Zonfa oversees the Health Services Management Department, which is responsible for medical management, utilization management, pharmacy benefits administration, quality improvement, accreditation, risk adjustment, regulatory compliance, appeals and grievances, provider support services, and clinical informatics. In his current role, Dr. Zonfa has focused on driving SummaCare's population health strategy by integrating clinical services throughout Summa Health. Dr. Zonfa is a board-certified obstetrician gynecologist with over 20 years of experience in the healthcare industry as both a clinician and healthcare executive. In addition to health plan administration experience, Dr. Zonfa has expertise in the area of patient safety, risk management, and quality improvement. Prior to joining SummaCare, in 2013, Dr. Zonfa served as Chief of Women's Services and Senior Physician Director of Risk Management and Patient Safety for Kaiser Permanente, Ohio. He earned his medical degree from Northeastern Ohio Medical University and an MBA from Baldwin-Wallace University. Panelists, welcome and thank you for joining today. One last thing before we get going, the learning objectives for today's keynote panel are as follows. Understanding how COVID-19 has impacted the strategy and perspectives of sleep and respiratory medical device companies, highlight the rapid adoption of telemedicine and other non-traditional mediums for screening, diagnosing, and treating patients with respiratory conditions, and finally, overview of the insurer's perspective on healthcare reimbursement on sleep and respiratory disease management, equipment, and services in light of new forms of care delivery. So, again, welcome. Let's jump right in. The public health emergency highlighted or accelerated a number of things that impacted our industry and healthcare as a whole. This first question is for each of you. What is the most surprising and exciting thing that you have seen change in healthcare due to COVID-19? And then how has that impacted your organization as a result? And if we can start with Dr. Nunez.
Sure, thank you. And thank you for having me. It's great to be here. So one of the things that I think really happened very quickly for ResMed is that this crisis began about 2 years ago exactly, late November, early December. ResMed is a global company, does business in 140 countries and in China. And our folks on the ground in Wuhan let us know that something was going on, and we were starting to see the need for large numbers of ventilators and bi-level devices. So for the last 2 years, we've been in sort of a crisis mode, if you will, because we had to deliver about a year and a half's worth of normal ventilator production in the first several months of the pandemic. But what I really learned the most, and I think it's a lesson that is not just applicable within inside the four walls of ResMed, but everywhere, is that people, their health, their well-being, their safety really, really matter. And we have spent an inordinate amount or a lot of well-spent time focusing on just that. We've proven that we can be extremely efficient working remotely, and even though video conferencing isn't perfect, we made it happen. We delivered those ventilators to the people who needed them to breathe and to save lives. But more importantly, and probably more admirably, we stood up for our own people. We made sure that people could feel safe and secure and healthy in their own homes. You can't show up to work and do your best if you're worried about taking care of your children, schooling them at home while you're trying to do a video conference, half a room away. You may have loved ones or elderly parents or people you care for who are very scared and worried about getting sick. And the last thing I'll mention is that COVID has also accelerated a lot of the thinking in healthcare in general about what does the future of healthcare delivery look like as we emerge from the pandemic. There had already been efforts to do more around things like remote monitoring, telehealth, the overall umbrella of digital health in general, where patients can be more connected to healthcare no matter where they happen to be. And most of the time, they're not in a healthcare facility. And I think in the right way, many of those things have been accelerated. The hard work starts now. How do we turn this into something that is sustainable and will allow us to actually modernize and improve and make more efficient the healthcare delivery that patients deserve? Being locked in your house, you've become used to a level of technological prowess with apps and your computer and your phone. Consumers are demanding the same of healthcare. They want to know why healthcare doesn't work the way the Amazon app works, why it's not so easy and so seamless. So those are the few things that come to top of mind for me.
Thanks so much, Dr. Nunez, and it's a great reflection that we've come so far, but we have so much further to go. So I appreciate your perspective. Dr. Teng?
Thank you as well for having me on this panel. It's a really exciting discussion. So I will start out with sort of a funny remark, which is that I think it shouldn't have been a surprise to us, but it was a surprise to us how successful the masks are and hand washing is in reducing spread of disease. It really is sort of funny because I laugh with my family about germs and how germy human beings are and how we were really able to make a difference. And we're still wearing masks. in our clinical settings today. But really, I think the biggest change that we saw in COVID was the adoption of virtual care. So we had plans to start telehealth and virtual care even before COVID, but COVID just pushed us forward like overnight. It was unbelievable. We changed all of our workflows, educated everyone. We flipped all of our visits from in person to virtual care, again, literally overnight, and sustained that for the most part over the last year. So before coming to Babylon, I was at Metro Health, which is the county teaching hospital in Cleveland. And we take care of a lot of Medicaid patients. About 40% of our patients there were Medicaid. And we really found that even patients that we thought would not be adopting telehealth were very open to it, and it actually improved our access and our ability to take care of them. And reimbursement changed with us. We advocated for that. Reimbursement changed with us to allow us to continue to take care of patients over the past year with telehealth. And so I think that's been our biggest advance. For me personally, of course, that has also changed the direction of my career, because I have now joined this company, Babylon Health, which is its mission is to provide a tech-forward virtual care, value-based care model to everyone, and allow access around the world to everyone, regardless of where you are in the world. So lots of changes, and thanks again for having me on the panel.
Thanks, Dr. Teng. Appreciate your perspective. And Dr. Zonfa, I would love to hear your thoughts as well.
Sure. Again, thanks for asking me to be on the panel today. Happy to participate in this discussion. I would reiterate what my colleagues have said about what is surprising. One is the fact that we had a hand washing campaign again, and this time it was embraced, thankfully, more readily. But I think the biggest surprise for me was the fact that organizations can be so flexible and so adaptable. So I remember having the conversation with my team at the beginning of the crisis. What would it take to move to a virtual organization if we had to do that? And within 7 days, we were actually having those discussions and implementing a process to become a completely virtual organization. So at that point in time, there were very few individuals working from home. And yet within 2 weeks, we had individuals pushing their desktops out on carts and loading them into their car, and we became a virtual organization. So I was extremely surprised at how adaptable and how flexible we were. And we saw that throughout every industry. The other thing is that was surprising was the ability of the provider network to respond quickly. So many of them had their offices closed for a certain period of time, especially in the beginning of first half of 2020, and they had to embrace and implement ways to meet their patients where they are. And I think that was extremely important, because what we demonstrated is that healthcare doesn't have to be provided in an office setting on a one-on-one type of basis. It can, in fact, be provided at the home or in other settings, and that we need to figure out a way to provide that care. And so, quite honestly, our patients truly embraced that option, and the amount of care that was being provided through telehealth by the person's actual provider, so not necessarily using an outside telehealth service, was extremely refreshing, and the ability to do that, I think, taught us and taught the provider network some valuable lessons in how to provide care.
Thanks so much for the perspective, and you're right. This couldn't happen without the engagement from the patient and the willingness to do that, and I think each of you really spoke to that. One other question that I'd like to kind of throw out to the entire group. We have been involved in a respiratory-related pandemic, and respiratory therapists and durable medical equipment providers delivering life-sustaining oxygen and ventilators have really been at the center of all of this. And so just wondering, do you think that the disease management of respiratory therapy and the DME channel has gained more respect from the medical community along the way as a result of this? And it's a question for everyone. I imagine Dr. Nunez is slightly biased towards favoring this. So maybe let's start with Dr. Teng.
So I think yes, from the medical community. I don't know if it's more. I think it definitely put respiratory therapy and respiratory services on the at the top of the radar. I think there's always been respect for respiratory therapy and respiratory services. I mean, it's just part of the continuum of care that we deliver for people. And when they're very sick, needing some sort of respiratory therapy versus even when they're not as sick, there are people with, mild asthma, COPD who also need respiratory therapy. So I think from a medical service, medical delivery standpoint, I think it's always been respected and certainly was even more respected during COVID. I think I was thinking about, general public, and I think what I wish had been highlighted more was the role of respiratory therapy and respiratory services to the general public. I think that we got glimpses of it in the media, but really not enough. That I just think it's an opportunity that we might have missed. And I'll give you, an example that, this is from my own family, that my brother-in-law lives in the state of Maine. And, he's educated. He works for a scientific company. And of course, he has physicians in his family. It's us, me and my husband. And we talked about it all the time in terms of why we were recommending vaccines, why we were trying to keep people at home to work, why we were keeping our patients at home, because we were concerned about hospital beds, we were concerned about ICU beds, we were concerned about ventilators. But I don't think it really hit home for him until he had a family member of his wife's who got COVID and ended up in the ICU. And he was actually in a situation in which they had to search to another state for an ICU bed for him. And so I just think, and I guess I'm telling the story just to say that I think that there was maybe a missed opportunity for the general public to really understand the value and the importance of respiratory therapy, because I don't think it was highlighted enough.
Thanks, Dr. Teng. And it's a good reminder, we all have a lot of work to do to continue to talk about, community health and all the different components of it. Dr. Zonfa, any feedback from that as well?
Sure. I think that prior to the pandemic, we were very focused on the care that's delivered in the hospital setting. So in that particular setting, the value of respiratory care, I think, was appreciated and respected. But when you look at the care that happens outside that setting, so DME and the care that was provided, it seemed like something that happens out here. And what the pandemic showed us is, one, people were reluctant to go get care in a hospital setting. They were reluctant to transition from the hospital setting to post-acute care facilities because of things that were being highlighted in the media at that time, especially early on. And so many individuals were seeking care in their home setting. And in fact, we have hospital systems that we work with that now have developed hospital at home care. And so I feel that, in that particular setting, the value of respiratory care as being a part of that care delivery team in the outpatient and in the home setting is now extremely valued. And so if there was a time where maybe individuals didn't recognize that value outside the acute care setting, I think they realize it now.
Yeah, that's an important distinction, and so many of our attendees today have a piece in that healthcare delivery that they may have worked at some point in the acute care space, but there's, to your point, so much that happens once the home is introduced, and a lot of opportunity for keeping that patient protected and out of the hospital. Dr. Nunez, would love to hear your perspective as well.
Sure, and I am a little biased, but only because I'm a human being. And I like to say that, you know what? Everybody breathes and everybody has to breathe. You can go days without eating, probably a couple days without drinking water, um, but you can't go but 5 minutes without breathing before you're dead. It's the most important thing we need to do every single second as human beings. And the pandemic did throw this into the spotlight for two reasons, just like my colleagues on the call said before. There was the acute care that happened in hospitals and ICUs because the very sick who contracted COVID ended up in ICUs, lots of them on supplemental oxygen, high flow therapy, many of them intubated, and very high mortality. And so the respect, I think, for respiratory care in that acute setting did absolutely rise, and at least the awareness rose. But absolutely, the reluctance for people or the inability for people to receive care in an inpatient setting or even in some outpatient facilities because they were either closed or inundated with COVID patients for the other types of respiratory disease, for other conditions that affect breathing, sleeping and breathing, definitely drove not just greater utilization of pathways like the DME channel, but a greater awareness of just how important respiratory care is outside of COVID. We saw last winter, although we may not see it again this winter, a very low incidence of flu because people were taking things seriously. I think Dr. Teng said at the beginning, who knew that we could prove so quickly to the world hand washing really does work and wearing masks really, can stop or slow the spread of respiratory diseases. And so I think the overall awareness and respect for the importance of respiratory care, how important it is just to be able to breathe, will definitely be something that is carried forward. And I think when we look at things like a greater awareness on respiratory disease, chronic diseases, and also this long tail of COVID, there are people who are experiencing many symptoms and conditions related to COVID infections that are lasting for months now, maybe even longer, may open up opportunities for more care in the home setting, more care outside of the healthcare facility as we deal with an unknown number of patients with a long-term consequence. So overall, I think it's a big eye opener, a gain in respect, and an opportunity for even more gain in respect.
Great. Thanks, Dr. Nunez. Let's switch gears a little bit. Dr. Nunez, most of the attendees are familiar with your organization, ResMed, and ResMed has long been invested in data and being a connected medical device. How has the pandemic impacted that?
Great question. We talked about it in the first question that you asked about the proliferation of remote care, virtual care. You had remote physiologic monitoring codes. Now we've got remote therapeutic monitoring codes for reimbursement that are going live. This greater push towards a digital health future where what I mentioned before, the consumer's expectations of technology in general are in many ways driving their expectations of what medical technology is going to look like and work like for them. We've also uncovered during the pandemic tremendous disparities in access to healthcare and gaps in coverage and access for some people and some populations. We knew they were there. The reality of the pandemic and the public health emergency maybe exposed how deep some of these inequities and disparities are. And the good thing about this concept of digital health, of pushing care to the patient in the palm of their hand on an app or through a connected device, becomes more important because you can close some of those disparities. Not everybody can take a day off from work without losing a day's pay to go and follow up with their physician for a chronic disease, a visit to check on their chronic disease. But a lot of people have access to a smartphone and can take time off to do a 5 or 10 minute video visit. But we've got to get that stuff right. It's what I referred to in the beginning, this opportunity. The pandemic has accelerated our thinking about how virtualized care and digital health and remote monitoring and telehealth can impact in a positive way the lives of patients and the efficiency of the healthcare system. Now we get to do that. And ResMed has been on this journey for about 7 years. You know, the AirSense 10 platform, sorry not to get too jargony or ResMed, but the platform that we released 7 years ago with our PAP devices contained a cellular radio. And it was put in there to make it easier to collect data about compliance for billing and reimbursement purposes. But an unintended consequence of this was that it also allowed us to better understand how patients use their devices. And it's led to a lot of clinical research that the team inside of ResMed, my team, the medical affairs team, has done in collaboration with some of the top key opinion leaders, academics, and researchers around the world to show that connected care really matters. It helps patients become more adherent to therapy, whatever types of therapy it is. It helps their clinicians and the providers understand what's happening with individual patients and across populations of patients. So as you watch ResMed's strategy in particular evolve over the years, this concept of connected devices becomes more pervasive. The concept of a software app-based ecosystem that connects patients to their providers, to their therapy, and gives them insights that they can act on, that makes care more effective and more efficient, is the horse is out of the barn, and it will not stop. It will, if anything, will become stronger and more pervasive.
You know, it's such a great call out. You know, we all need visibility to what's going on in the home. You know, it's very difficult to help support a patient through their care journey if we just don't know what's going on. Dr. Teng, in your prior roles in major health systems, as well as your position now as the Chief Primary Care Officer for Babylon Health, you and your teams are responsible for many patients. How do connected devices help remotely manage those large patient populations?
Yeah, so I think I'll just start this conversation by saying completely agree that this connected devices and virtual care have really helped us address healthcare disparities. And I think it's really changed how we think about what patients want. And I don't think what they want has changed, but maybe our willingness to listen to what they want has changed. I think, you know, traditionally we have made patients come in to see us between 8 and 5, Monday through Friday. And really a lot of patients don't want to come in. They are working or they're at home and they just don't want to come in. They would rather pick up the phone or get on a video call. So I think that's been a very important shift that we should continue to strive to meet patients where they are and where they want to get their care. So in terms of connected devices, certainly we launched some programs around hospital at home. So we were using connected devices to keep people out of the hospital. So specifically, these were COVID patients who were not really sick enough to need to be in the hospital. They could be managed at home, but they had devices in which we could monitor them from their home setting. In addition, on the ambulatory setting, there's lots of opportunity for us to use smartphone devices, blood pressure monitors, lots and lots of data points to help manage people remotely, again, from their homes or their workplaces or wherever they are needing and wanting their care. I think right now this is very individual based. It's helping us deliver that one-on-one care, that personalization that people want and customizing their care based on their individual data points. I think over time, as we collect more data from large populations, we'll have a better sense for how we can maybe predict people's needs and intervene a little bit more quickly or sooner than anticipated. So I would say that, again, the connected devices are super important in terms of the data points that allow us to make those sorts of clinical decisions along with patients, and agree with what my fellow panelists were saying about patient engagement as well. Very important because people obviously will respond better to their own data points and when they can see progress, especially.
Yeah, it's clear that it can't be a one-size-fits-all. There needs to be a personalized approach for each patient, and the data can really help us transform what the care plan looks like. Dr. Zonfa, how does a health plan look at connected devices? And I assume you want your members to be optimally managed with the greatest value and the lowest cost. talk about where you see connected devices going in the future and how did COVID impact that from your perspective?
So we look at connected devices from the health plan payer side very favorably. Um, but I want to touch on one thing that's extremely important that was said is that um, for years we've been talking about meeting patients where they are, and whether that's they like to be texted, they would rather do a video chat, they would rather be called on their cell phone. Um, And yet, as providers and clinicians, we haven't necessarily done that. And I think that COVID has changed that. So I cover the Women's Health Center at Summa Health, and our providers are now that they're not expecting only to have a face-to-face in-office visit with a patient. There's a much more acceptance and willingness to have a video chat with the patient, even if it's not during a scheduled time or scheduled visit. And those when we try to call patients from the offices, a lot of times we don't get a response. And yet, our response rate in calling them on a cell phone or texting, even, has been tremendous. And so I think it's impacted healthcare very positively in the fact that the provider side is starting to embrace those types of interactions as well. From the connected device perspective, from a health plan, we've embraced connected devices. For years, we've had a home telemonitoring program around the care of congestive heart failure, and that has been extremely positive. There have been specific protocols built to manage those patients based on the data that we get back from those connected devices. But now it seems that there's market proliferation of what these devices can do and what we can manage with them. And so I look at it as typically we've always thought of connected devices for wellness. So you wear a Fitbit or an Apple Watch, and it checks your steps and monitors your heart rate, and it's all been focused around wellness and fitness. Now we're starting to look at connected devices, um, and I think COVID has helped push this idea in a way to use them not for wellness but for management of chronic diseases. And so I think that's extremely important that we continue to do that. At Summa Health, we're looking at ways to partner with manufacturers of connected devices in how we can best integrate those and the information into our electronic medical record. Now, with that comes some 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 other complexities in managing our members and patients, and the fact that for some connected devices we get continuous data. When you have continuous data, as a clinician, you're used to typically looking at data in a very static fashion, and now you're getting continuous readouts from a connected device. And I think that we need to be cautious about how to interpret those because they will be interpreted differently, and and we will need to develop protocols around who's monitoring those, how they're managed, how often we're looking at those, and what types of interactions based on the data that we receive are needed. So we have partnered with a connected device company that does home telemonitoring and coaching around various disease conditions. And it's been extremely well received by our membership. And we are continually looking for new opportunities to manage different disease states. Again, looking at depending on where you are in the continuum, if you're healthy or someone with a chronic disease that's well managed and stable, those interactions will be different than someone who appears to be struggling or in crisis in managing their disease condition. So we need to be cautious about how we use those connected devices to manage those patients.
That's great. Thanks so much for your perspective. And we've talked a lot about connected devices so far, but I think one of the things that none of us really know is what will the in-person versus virtual visits look like, when we're all through this. Dr. Teng, I'm interested to get your perspective on, from where you sit as well as your experience knowing that we've all been forced to operate in a virtual environment, but where will we land at the end of this?
Yeah, that's a very interesting question. I just for some data points, before COVID, I would say less than 5% of our visits were virtual. Just after COVID, when we had to convert, more than 95% of them were virtual because we had to do that. And then over the course of the year after COVID, it leveled out to about 50-50 in primary care. But I would say that 50-50 was really in the context of not having connected devices. And I think that there's an opportunity to increase that number even more. I suspect it will land closer to 75% virtual, 25% in person for primary care. Obviously, for other specialties, it may be different. But I think the number could go up to 75% in primary care with the data points that we need from home and the ability to maybe do some home lab monitoring and other sorts of monitoring. And I think that is really that's sort of the big experiment that's happening now, whether it's in traditional healthcare systems or whether it's in companies like Babylon. It's trying to figure out where does virtual care fit in the continuum of a patient's health, and for which patient populations does it really make a difference. So that's the big question mark that we will hopefully get information for over the next year or two.
Dr. Zonfa, how does a payer like SummaCare look at that? I guess the trade-offs of the in-person visit versus the virtual. Is there more value, perceived in one versus the other from your end?
So there's a give and take, right? So I think that we look at virtual care as really, is it the right and most appropriate level of care? So as a payer, we're always more concerned about appropriate level of care for the specific condition being managed. And there is definitely a place for virtual care in very specific conditions that lend themselves even better to managing through virtual care. Behavioral health comes to mind as one that we found patients are more compliant because there's that little bit of anonymity in a behavioral health virtual visit versus an in-person. But again, I participated in a national group that was looking at. We're trying to answer, where is telehealth going in the future? And I think the short answer was we don't know. We don't know, but we have changed the perspective of the providers in how they think about virtual care, and it's more readily accepted. And so, as a payer, we embrace that because, of course, we want the most cost-effective, high-quality care. Where we're running into issues as a payer, though, is that the government, our largest payer, is not embracing virtual care in quite the same way and the magnitude needed to do the things that they require us to do. And one of them is really risk adjustment and making sure that we're capturing the disease burden of the population that we're managing. And so the government, being a little bit slower in embracing that, has caused us to have to be a little bit slower. But we'll work that out. And I think that virtual care is here to stay.
Aren't we always a little bit faster than what's going on at the government?
Depends on your definition of a little bit, but
Right.
Typically, yes.
Yeah, there's a sliding scale. So talking a little bit about screening and diagnosing patients and that challenge or new opportunity, whether you're an in-person environment or virtual. Dr. Nunez, ResMed has been an advocate for identifying those undiagnosed sleep disorder breathing patients across the world. I think from your team's research, you estimate nearly 1 billion people in the world have some sleep disorder breathing. What can the entire healthcare channel do to better identify these patients? And is there anything that we've learned during the pandemic that's helped that?
Great question. And it's That's actually one of the pieces of research I'm most proud of being involved with, because we reset what the thoughts are around the global prevalence of this disease. I mean, it's nearly 1 billion people around the world that suffer from sleep apnea. That's more than COPD, that's more than diabetes, more than heart failure. And it's a disease that's interesting because it can be quite devastating, but it happens at sort of a slow crawl. And the other things about this disease are the diagnosis can be much more expensive than the ongoing therapy. And so, and Dr. Zonfa, please correct me if I'm wrong, but from a payer perspective, where you don't know if your patient's even going to be your patient and enrolled in your plan next year, and there is turnover, it's difficult to understand or justify, why do I pay thousands of dollars up front for the diagnosis for to help a patient 30 years down the road that may not even be my patient in a year. So it's been an interesting sort of clinical and economic struggle that is well worth having, because we need to understand this disease. We need to understand the ramifications. And it speaks to an opportunity to streamline the patient pathway, especially at the front. Let's make sure that screening and diagnosis can be as efficient as possible so that we can identify these patients. More than 80% of that billion patients around the world are undiagnosed and untreated. And we are setting ourselves up for an avalanche of chronic conditions and devastating comorbidities and sequelae from this down the road. I'll give you just one example that keeps me up at night. We are starting to see more and more, through not just basic science and physiologic research, but also even retrospective studies of claims data, that untreated sleep apnea increases the risk for dementia, especially Alzheimer's dementia. And we need to understand, how can we get these patients identified and treated in the most cost-effective manner so we can prevent, a devastating avalanche of dementia in 10 years, 20 years, 30 years, because so many went untreated. It's a simple example, but it speaks to the importance of this disease and the importance of working together with all of the stakeholders, starting with patients, with clinicians, the people who are paying for this care, and the regulators who are setting up the rules under which we not just operate, but reimburse the care for these patients, so that we can truly understand why this patient journey seems a little bit broken and how we can make it better for all the stakeholders involved.
And we hear so much about that journey and the road often leading back to the primary care. So, Dr. Teng, so many of our attendees are affiliated with the DME or work closely with them while managing patients. Oftentimes, we're caring for these patients during an exacerbation prompted due to a lack of attention to their own care. With organizations like Babylon Health and other virtual visit platforms, how can we better align with primary care providers to help with this?
Yeah, it's a really good question. And I'll just say, from a national sort of systems viewpoint, I think we all have the same goals, right? Our goals are for better health and outcomes for our patients, and for them to have access to care where and when they need it. And along that trajectory, how do we best engage them in their health? And so I think the lowest hanging fruit, obviously, is a lot of what you try to do today, which is to make it easy for us as PCPs and as patients to access the devices that we need. So the processes that you put in place to make it easy for us to get patients what they need. That's super important. I think the future is going to be more around what sorts of devices can we create and put in people's hands to help them with self-monitoring, self-testing, and then be able to feed that data back to the primary care providers so that we can help the patients, make sense of that data and help them with their own health goals and their health journeys. So I think that's really the future, and keeping those lines of communication open and those relationships moving forward, because again, we have the same goals for patients.
Thanks so much, Dr. Teng. And everything that we're talking about is related to connectivity and transparency and visibility. Dr. Nunez, I imagine there are opportunities to leverage the connected devices to offer leading data versus lagging. Leading data may help DME providers better predict an upcoming episode, that would adversely impact the patient's health as well as the payer's pocketbook. How does ResMed look at the distinction of data reporting, and where should we expect that data reporting to go?
Great question. Yeah. We have seen in the consumer technology world that when you start to accumulate large amounts of data about people, you actually know much more about them than we ever thought possible. I mean, you've heard the terms probably surveillance capitalism, which are the ways they describe the business models of companies like Google and Facebook and others. Um, but in a non creepy way, as medicine continues to gather more and more data about patients, we don't need to be like a Facebook Cambridge Analytica uh, sort of approach to this. What we can do is use this data for good. Use this data to change behavior in ways that matter, like adherence to medications, adherence to therapy, adherence to a plan of care or wellness. I think what you're going to see is as we get better in healthcare, in med tech, at using large sets of data in real time or near real time, streaming from these connected devices, that the intelligence will be built into these software platforms that we built into this app based and software based ecosystem. So the research that used to take years to complete, or even the real world data types of research that only take weeks to complete, will happen in real time on your device. The device will be a learning device. The healthcare system will be a learning healthcare system. The National Academy of Medicine several years ago said that we want to foster the creation of a learning healthcare system, and that's what this, these large sets of data and an appropriate, ethical, private, patient-focused, provider-focused approach to these data will allow us to do. It will allow us to take an application like AirView, which looks retrospectively at patients and flags those who may have had leak or who may have had problems adhering to therapy, looking at yesterday's data, and in the future, in the very near future, maybe even today or tomorrow, wink, wink, start to predict which patients are going to have trouble adhering to therapy based on patterns from a whole universe, a vast population of patients that came before them. And that's my example, but throughout the entire learning healthcare system that we're building, by using and exploiting in the right way these data that we have access to, we will make patients' lives better. We will improve clinical outcomes, economic outcomes, and allow the system to predict and to tailor care and care delivery in ways that save money, that are more efficient, and still drive those better outcomes.
It's a powerful thing to reflect on. And Dr. Zonfa, from your seat, I imagine that much of your payments to providers right now are really episodic in nature or reactive. But can you talk a little bit about that from your perspective? Obviously, what you want to see, where you see it going, how quickly, and how that impacts a payer.
Sure. I love this question because it actually forced me to really think about, I always look at our total spend. And when you start to look at it from the standpoint of, is this reactive money or proactive money being spent? I think that's such a great question because when I looked at what we're spending in the outpatient services, we bucket it versus primary care versus specialty versus preventative codes. And about 20% of our spend in the outpatient is preventative codes. Almost 50% is at specialty. And then the remainder is in primary care, which is probably some preventative versus some reactive. But to Dr. Nunez's point, we looked at the spend regarding an advocacy program we were trying to do at the state level to cover uh, more intensive screening for breast cancer. And I was asked to pull our data, and what I found is early stage breast cancer cost the health plan in medical spend about $2,000 to $3,000, where advanced cost the healthcare system $50,000. So, um, you know, with with things like sleep apnea devices that tell us whether or not someone's being compliant, or we're monitoring medication adherence, which is very easy because do they get the prescription filled or do they not? The question comes to, well, what do you do? Do you just stop the medication or take away their CPAP device? Or do you or do you, what we do, I'll say, is we engage our care management team to do outreach and to try to determine from that particular individual, why aren't they being compliant? Maybe there's something very simple that would allow them to become compliant. And so from a medication management standpoint, we try to determine why they're not getting something filled. And maybe it's a cost issue, maybe it's a transportation issue. But there are things that we now have at our disposal with the health plan to help address some of those particular issues. And I think that's extremely important, because if it just comes to monitoring and no use means you don't get access anymore, I think that would be the wrong approach.
Great. Thank you. And we're glad to challenge you to think in that way as well. We all look forward to seeing more value-based payment arrangements where we can all work together to drive value into the whole healthcare continuum. We've just got a couple minutes left, so I want to wrap up with one final question for each of you. And this one might be a little self-serving, but how do you see DME providers establishing a greater relevance and responsibility in healthcare in the long run? And I'll start with you, Dr. Teng.
So I think we've hit on this topic a little bit, but I just want to reiterate that I think data is really important. I mean, I think right now you deliver DME companies deliver great service, great patient care, but I think the future is in data and being able to shift from more sort of traditional delivery to data sharing, data gathering. And I think there's one other opportunity, which is that as more virtual companies come into being, there's an opportunity for the people who are delivering DME and working with patients in the home to be the eyes and ears for providers who are virtual. So I think there are a couple of opportunities there.
Thanks so much, Dr. Teng. Dr. Zonfa, same question for you.
I look at it from the standpoint of there has to be more integration within the care management team. And so I look at that, what COVID has taught us is that people that are admitted to the hospital can sometimes be delayed in getting out because we don't have a plan in action. And now that more care is moving out of the hospital setting in the acute care setting, there's a definite role for DME providers to sit at the table and to help develop the strategy for the most appropriate care and make sure that individual has the resources and the supplies needed when they transition to home or their next level of care. And so what we found is value when we're thinking about what an individual needs and how do we meet those needs from everyone on the team.
Thanks, Dr. Zonfa. Appreciate your perspective. And Dr. Nunez, would love to hear from you as well.
I think both of my fellow panelists hit on probably the two most important points. One we've talked about a lot, and it's the use of data to generate insights that can improve the patient's experience, streamline that patient journey, help with those transitions of care. And as Dr. Zonfa said, this approach where it's really a more collaborative and holistic view of this patient journey, especially when the patient leaves the healthcare facility, giving the DME a seat at the table, an opportunity to help inform what that strategy should look like, giving the DME and that entire DME industry more credibility to really have a say in what the future of the patient journey looks like outside of the hospital, how to streamline the provisioning of care, and using data to make that care more effective and more efficient. It's a really exciting time for, I think, all of healthcare to evolve quickly into what the new normal looks like. And as we push more and more care out of acute care settings, the DME is perfectly positioned to improve that patient journey and as I said, inform that strategy and be a more important stakeholder in the entire patient pathway.
Well, Dr. Nunez, Dr. Teng, and Dr. Zonfa, I can't thank you enough for being a part of this. It's been a very exciting discussion. We're at the top of the hour, and this concludes the keynote panel. And for all of our attendees, you've got a 30-minute break, and we will see you on the other side. Thank you all so much.
Thanks, Josh.